Hi, everyone. Hello. So good to see some of you. Welcome, everyone. Welcome, everyone. I think we can go ahead and get started today. Thank you for joining our January Research Roundtable. We have just a few quick announcements that will let Dr. Miele get started. Today, we're so excited to introduce Dr. Miele. She's a fantastic pediatric neuropsychologist at Children's Hospital Colorado and an essential member of our clinical team. If you have had the opportunity to attend clinic, hopefully you've gotten to see Dr. Miele, and if not, then hopefully she is on your list for your next visit. Today, she will be sharing updates on the behavior and developmental insights from the AP Heroes she's seen. But before we dig into that, we'll go ahead and let our executive director, Dr. Chaby, start with a few quick announcements.
Thanks, Katie. Thanks, Dr. Miele. And thank you all for coming. We're so excited that you've been able to join us today. We just have a couple of quick announcements. So it'll only take about 10 minutes, then we'll get to the meat of it, and then we'll have a Q&A. If you haven't had a chance to submit questions in advance, please feel free to put them in the chat as we go, as they come to you. And we're really looking forward to being able to engage with you. So we have new surveys. So there's a survey here, our AP care needs and financial impact. And this is really helpful for us to understand how we can best advocate for the AP community. So this is why we get this information, is so that we can really use it to put those pieces together to push for the support that our community needs. So this is really helpful when you're able to complete this for us. We also are so thrilled that we have our Mapping the Mind initiative. So we have research projects with researchers that specialize in MRI scans as well as EEG data that are actually digging into these data for us now to look for signatures of AP, as well as quite a number of other pieces that will help us understand more about AP and the variability, as well as specific opportunities that there may be. So this is ongoing now. And if you haven't had a chance, but you have existing MRIs or EEGs, it would be incredible if you could share this with us so they can include it in their evaluation. We also are super excited to share that along with Uplifting Athletes, we've awarded Dr. Yanning Zhao an investigator award for 2025. She's going to be working to evaluate some transcriptomics data that we already have in-house, which is really a wonderful opportunity for us to expand the impact of data that we've already generated and really get it to the next step. So this is going to be starting here in February, and we're really excited to share updates throughout 2025 about this. Also, just sharing what I've said. So this is really an opportunity for us to come together as a community. We'll share recordings afterwards, and please continue to submit questions through the chat as the conversation progresses. And our next research roundtable, save the date for February 24th. Katie and Tobias will be talking about our patient passport, which has now launched. So if you haven't gotten a patient passport and you would like one, please reach out. We would love to provide you with one. And we'll talk then about how they're being used and a little bit of a sneak peek for the Passport 2.0, and dig into a little bit of how these can be used. And there's a publication and prep to be able to disseminate this to the broader rare disease community. So we're really excited about this. Also, for Rare Disease Week, which is at the end of February, we're having an event where folks will read So we're calling it 8 minutes of connection story time with AP heroes. So we'll have volunteers that will join a Zoom and read. We have a selection of storybooks for our AP heroes. And just as a personal anecdote, it's just so sweet. When I'm able to do Zooms and our beautiful AP heroes within our Project AP Immediate team come on and get so entranced by the Zoom. So hopefully others find that their AP heroes are similarly entranced by talking heads on Zooms. So we're hoping that this will be a fun event. But yeah, so we'll be sending out an email at the beginning of February as a call for participation in this. So just as a placeholder there. And with that, Katie did a beautiful introduction, but we're just so thrilled to be able to have this as an extension of the initial conversation in our Family and Science conference in July. So it's just so tremendous to be able to revisit that as well as some new updates, and really looking forward to the conversation. Thank you again.
Absolutely. I love that 8 minute the story connection. That sounds so fun. Well, hi everybody. Thank you for joining this roundtable. I'm really happy to be here, and I am hoping that the information that I present is helpful to everyone. As was said, happy to answer questions. Happy to answer questions in the chat, or if you have a question that flies into your mind when I'm talking about something, feel free to just interrupt me. I don't mind that at all. And if you did attend the conference in August, some of this data you might be familiar to, but then I've added to it because we've had some more families come through clinic, and I've gotten more data, so I've gotten to do a little bit more with it. So hopefully it won't be just a repeat for everybody on the call. Okay, so let me share this again. And let me get it going. Okay, so there I am. So I just wanted to start with just kind of the key points. So kind of tell you what we're going to be talking about, and then I'm going to talk about it. I am a pediatric neuropsychologist, as has been mentioned, and I do feel that neuropsychological evaluation is really important for all kiddos or individuals with AP. I do think it can guide steps along the way at any age. So if it's something that your family is interested in, I hope that you have the opportunity to either get an evaluation done at an institution or come to our institution. Because of families coming through our institution, I've been able to kind of look at our data, and I do feel that there's variability, of course, but the changes that we see in AP do have kind of different cognitive profiles that are starting to become apparent. And so I think that this is important information because it can be used to help families kind of prepare for the future. So as I'm saying, so now since I have more data, I'm able to start to be able to look more about how the size of the change specifically, and then eventually the location might also kind of affect development. So that's some stuff kind of coming down the line. Okay, so to just kind of like level the playing field for folks who maybe have not been in the literature for for AP. So there's this really seminal paper by this, I think it's Viber, I might be saying that wrong, but published in 2021, who published on 36 patients with inverted duplication deletion. And they described them in terms of developmental milestones. In the yellow, I kind of have the percentages highlighted. So again, this is just in kids with inverted dup del. Where most had global developmental delay, all kids met for intellectual disability. Speech delays were prominent, but then some kids were able to learn to speak. Words were just acquired a little bit later, maybe, than some other kids. Most kids were able to walk, and then you can kind of see the percentages there where they like kind of qualify the levels of intellectual disability. So they kind of started here, which was a big contribution. And then our group, though, has been able to look a little bit further. So we have, this is one slide that divides, I don't suppose you can you see my mouse?
We can, yep.
Can. Okay, excellent. That will be helpful later. Okay. So these are the changes that we have in our clinic at the top. And again, that paper that I was just mentioning was just talking about AP inverted del dupe. So we have looked at, you can see the ages that we have. I didn't include this age because I just felt like there was only one kiddo, and so we can just leave the age out just for confidentiality. But we have, about half the kids kind of in the whole group, like sleep problems or something that we hear a lot about in clinic, which are definitely very impactful for families. About half the kids are kind of able to achieve toileting, which is another milestone. And even more than half are able to achieve walking. So those are kind of some of the percentages that we have broken down by change. And then we also have this information where we're asking about language, kids who use AAC devices, which is kind of around like a third to almost a half of our population who's come to see us. And then we have kids who have kind of any mental health or behavioral diagnosis, which was not included in kind of previous papers. And we can see that there's a significant proportion down here who have, this could be anything ranging from anxiety to learning disability or ADHD, hyperactivity, autism, depression, aggression, all things like that. And so we, in our clinic, thanks to the families who have come, have been able to add information like this that I think is useful. And so that paper again started with inverted del dupe only. Then there was this paper by Oker et al., who included more than just inverted del dupe. So they included kids with inverted del dupe and deletions. And these are some of the statements made from the paper. And you can see I have the first one kind of highlighted. And if you came in August, you already heard me talk about it, that I don't really love this sentence. I don't think it's just not, I just think all individuals are testable. And so I take kind of offense to this. So maybe we wouldn't be able to get like a standard, IQ value via like IQ testing, but everybody can show us what they can do. So I just wanted to kind of highlight that to say we're going to ignore that sentence, but we're still going to listen to their data. So they used parent report, the same parent report measure that if you've come to see me, you have filled out, that I know I'm sure is near and dear to your heart, called the Vineland. But they're the first ones to actually kind of publish data. So I was very interested to learn about it. So as had kind of already been reported, there was always kind of some degree of developmental delay and or intellectual disability, but kids with the deletions seem to have a milder cognitive difficulties than the kids with inverted del dupe. In fact, one kid with a deletion kind of at the distal end, this point here, was in college, and another was driving, so that I think was some really interesting information to talk about the variability that's present in these changes on chromosome 8p. So mild learning disabilities were reported, and then some kind of attention, anxiety, and depression, though, were also reported. So that was very interesting work that kind of came out in 2021. This is a picture of the Vineland scores that they have. And so we have the changes here down at the bottom. And this is just the way that they demarcated, I guess. So deletion in 8p on the proximal end, deletion 8p proximal and distal, versus deletion in 8p just distal. And one of their main findings that I have kind of highlighted is that communication was commonly a lower, kind of the most challenging domain, except for in this group. And then I have this line here at 70, just because it's a common metric that schools use, that neuropsychologists use to kind of demarcate one's skills once we really have a considerable gap between kids and their peers. You can see over here, I have kind of an average score would be a standard score of 90 to 109 over here. And then low average is kind of between these ones, below average here. And then, like I said, once we're below 70, we really have kind of a sizable gap. And so this is what they presented with the most kids in this group, and then still kind of never before reported scores from kids in these groups, just still a little bit small, but we know what it's like to work in rare disease, so gotta start somewhere. So then this is our data from Children's Hospital Colorado, and the same thing on the Vineland. So I tried to have it, I have it color coded so you can see which domain on the Vineland is the color, and then which group of change the kids are in. Again, we just have one kiddo with this change, so that's why it looks like stars instead of bars. And again, we saw that communication was a challenge in the duplication group and the inverted del dupe group, but also kind of less so in the deletion only group. But the other thing I kind of wanted to point out was that social skills were really a strength in basically all of the groups. These green bars are some of the highest, and some of the scores that are even like well into the average range. And so I feel like this is an important note to, for folks to know that while other areas might be challenging for these kids, they want to interact and they want to smile, and this can be something that can, I think, really capitalize on helping them participate in school and therapies and things like that. And so we want to also talk about strengths. I think that's really important as we're trying to. Families are working. I know you guys are all working so hard to have every moment of your child's day be an effort towards their growth, and so it's nice to be able to capitalize on some of those strengths sometimes.
Hey, Andrea, am I allowed to ask a question?
Yeah, sure, Zach. How you doing?
I'm good. How are you? It's nice to see you.
Good.
I was just chatting with Bean and Lauren and the AP leadership and Katie earlier today about the ABC in particular.
Mm-hmm.
That and thinking about many of the rare diseases that you and I both know very well, abnormal behavior is common for some of the other ones, but it wasn't clear. But it seemed like the 8P kids were quite sweet and sort of had this like very lovely disposition, which and so we were talking about the ABC test in particular, about its value in this population and whether you've learned much from it.
Are you talking about the aberrant behavior checklist or
That's one. Oh, does
Okay, so
ABC mean something different here?
yeah, so this is the adaptive behavior
Composite.
composite. Thank you.
Okay.
So this is all just from the Vineland.
Okay.
So
Okay.
I know the ABC, and I do feel like it pulls for, well, so this is kind of in the adaptive domain. The
Okay.
ABC is going to be more like behavioral, and especially really significant behavioral difficulties. I'm going to present like BASC and SRS data.
Okay.
Is
Okay.
more what I use like in the social emotional, social responsiveness domains. But I do feel like, actually, just to take this quick aside, like comparing the BASC to the ABC, the one that you're talking about, like the ABC might pull better than the BASC
You
does,
think so?
honestly.
Your qualitative sense is that it may be a better tool in this population.
For some of the really severely challenging behaviors, I kind of wonder if it is.
Okay.
I honestly, like, what I would need would be like aberrant behavior checklist data and BASC data, at the
Yeah.
same time to be able to compare.
Okay.
Um, but we're gonna see the BASC data like in this population, and I do wonder if the ABC is maybe it's
Thanks.
shorter too. So
Sorry to derail. Thanks.
no, that's okay. Yeah, ABC and all the acronyms, guys.
Hi, I had a
Sure,
question,
sure.
if that's okay. What's the sample size in these? Like on the last chart that you showed us, there was sample sizes under each.
Yeah, that's a great point. That I should have included that. I put the labels, but I didn't put this. So it's the same as
Same number? Oh,
these. So like 11, 11
okay.
or so it's these. So the biggest, so our biggest group is still inverted duplication deletion, but we had a lot of families with duplications only come to see us. So that number got bigger for us. And then kind of 3 dupes only, and then 1.
So the other chart that you showed us from the other,
This.
from that one. So like, for example, in Dupdal, they had like 39 subjects and we have like 13.
So
Okay.
I have 13. Yeah. So they have more
Yeah.
than we do right now for this. What they don't have that I was, if it's okay to move on. So what they don't have are any kids with duplications. Like that, but that, you know, because they split out their deletions into these kind of domains, which we haven't done. But these are kind of the ends. Yeah. So they do have, so they have like more in one group, but they don't even include one group. And then we have more in another group a little bit. So trying to add to it over time. So this slide just shows kind of a comparison without the bars of this versus this, the kind of the scores. And some of the places where we are aligned kind of with the ochre group, like if you sort of, I suppose if you average like all the deletions, you know, we're kind of close since ours is 65. They have this one kind of 45 here, but it's always kind of unclear what's missing when you sort of average, but some of it is like relatively close. Again, they don't have the duplications group, so we're adding that. And then our inverted duplication deletion is pretty close, 46 to 52. That's kind of within a standard deviation. And so, and then they don't have this, I should have put an NA here too. They don't have a kiddo with this change either. So we just have the one, but so we're kind of in agreement, and then, you know, extending the literature further, which is something that I think is kind of one of our big goals of our clinic. Okay, so now I'm going to try to take us through actual data, like neuropsychological data from the kids that we've seen based on their change. And so every graph is going to take a little bit of reorienting, but hopefully you guys can bear with me. So these are tests on this thing called the WIPSI, which is kind of a measure of early intellectual functioning. And I picked the ones that really worked the best in this group. And so we have age in years at the bottom, and then I realize I have age equivalents in months on this side, which is a little bit, we have to do math. And so what I kind of want to point out is that for some kids, you know, 4 years, 9 months, the dark blue, like we're pretty close to our age equivalent on some of our measures here. We have a little bit of a gap for some of the tasks, but not for all of them. Kind of similarly, we might have a little bit more of a gap for this 12-year-old, but we still are able to demonstrate quite a lot of skills. What these tasks measure, this one is like a verbal fund of knowledge. So we ask like, where are your knees? Where's your nose? Up to like, tell me something that grows in the ground, like questions like that. Object assembly is a puzzle assembly where they actually have to put together a puzzle. Picture memory is early working memory. So they're shown a picture and then they have to point it out later, and then it gets to 2 and 3 and 4. Receptive vocab and expressive vocab are just those kind of pointing to pictures that we say, where's the wallet? And then expressive vocab, they just have to name it. So for this group, that was kind of the other thing that I thought was interesting, was that expressive vocabulary was one of the strongest skills. The orange line doesn't continue over into this one because I just didn't have that data point for that kiddo. So, you know, at these ages, at least, we can kind of get a sense of perhaps small kind of gaps, but still like kids who are able to show us quite a bit and get kind of an IQ score. So again, kids are testable. We can do this. So kind of similar group. This is pre-academic skills. So as it says, it's like colors, letters, numbers, size comparisons. So what that measures is like which one is the biggest rock or the tallest fence, or which girl has the longest hair, questions like that. And then shapes. And so this one, so we have ages and years here at the bottom with percent mastery. So, this 4-year-old is still working on colors, but these two others, know their colors 100%. They know this kiddo knows most of their letters. This kiddo's still working on them. And then over here, this kiddo had more trouble with the sizes for some reason, but this kiddo, did a great job. And then I just sort of don't know why the shapes is not also in the same higher range as colors, but maybe that's just something that, schools want to move on to like letters and numbers, and so shapes kind of get missed. But for me in clinic, I feel like I'm often saying like, don't forget to work on shapes, just for kids to work on that too. So we kind of have these pre-academic skills, again, that kids are able to show us quite a bit that they know. And so then what happens when they're a little bit older, we switch measures onto this thing called the Wyatt. And I get standard scores. So these are the same types of scores that we had for the Vineland, where average is like 90 to 109, and we have the 70 line where we are noting quite a significant gap, but still these scores mean that kids are able to, recognize all their letters and read words for me. They're able to spell some words, probably, simpler words, maybe like consonant, vowel, consonant, but we can still do it. We can solve basic addition problems. Perhaps they're memorized, but I don't care if that's how your kiddo knows 3 + 3 is 6. And then math problem solving is more like little kind of early word problems. And so the other thing that's kind of important to have in your interpretation of this data that I realize is complex to work through is that the fact that these scores are all kind of hovering around this 70 line does not mean that kids are not gaining skills. It's just that as they get older, the expectations to be at a standard score of 70 increase. And so the kids are in fact increasing, like kind of as expected. And so that's why their score, even for older kids, is still kind of around the same range. But this kiddo, for example, who is 8, is still demonstrating more skills than kind of this kiddo who is 7 at that kind of same, because they're that much older. So in order to have that score, they still have to kind of demonstrate more. Hope that makes sense. It's a little bit hard to think about. But I also put these two together because the bracken is the one that we talked about on this previous slide with the colors kind of all broken up. But then what happens is you get this school kind of readiness composite. And so I just thought it was interesting that the standard scores are kind of the same, even kind of in the pre-academic space, and then kind of switching up to the kind of more standard academic skills. And so to me, this says like, this is great. We need to keep teaching them these skills because they can learn to do these, some of these skills. So that's kind of why I put those together. So now I have this kind of switching on to social responsiveness, which is a questionnaire that I have parents fill out. It breaks social responsiveness down into these domains here at the bottom. So we have social awareness, social cognition, social communication, social motivation, and repetitive restricted interests and behaviors. And it says T afterwards because they're all T scores. So for this one, the questionnaire after when we have a T score kind of above 65, which is where I have the yellow line, is where we start to say, okay, we might be having some issues here. And so you can see the ages on the bottom. And I also feel like the ages illustrate an interesting point that age doesn't necessarily predict if, it's not like, oh, as kids get older, we see more behavioral problems. At least in our cohort, it's one of our younger kids who's having the most trouble in this domain. But one of our oldest kiddos also has some trouble kind of in the social cognition domain. And the restricted interest and repetitive behaviors is kind of the one that's most commonly elevated. Again, I just have 5 kids in this sample, but so in 8P deletion, it almost seems like since kids are able to demonstrate more skills, they also might be at more risk for kind of difficulties in that social environment, and why it's important, kind of an important area that I would want families to have kind of counseling or evaluation in, because I'm 100% sure that this domain can really affect day to day for families. So that's kind of how this SRS shows up. Okay, so that was kind of our group who's come to see us who've had deletions. Now I'm switching into the kids who've had duplications. So we've got 3, and they're all kind of younger, on the younger side, 12 months old. This one is months, 12 months old, 32 months, 35 months. And so for these kiddos, you can see that we do have a bigger gap between their chronological age, again in months down here, to their age equivalent on the Mullen, which is a measure of, it looks at gross motor, fine motor, visual reception, receptive language, expressive language. And so there is some variability though. This kiddo who is 32 months is pretty close in a couple of domains, language and motor being the hardest one for that kiddo. But, and then the other 2 kiddos are kind of right around the same age equivalent, even though their age is quite different. So the 12-month-old is actually like added right where they should be for several, I guess it's just this one, for several measures, with sort of a smaller gap, and then we have kind of a bigger gap for this kiddo who's 35 months. So it already kind of seems that 8P duplication might have some more developmental challenges compared to the deletions. But again, we've only seen the 3 kiddos who are young. And so now I have, this is our inverted duplication deletion kiddos. And so I'm not sure if I have everybody on this slide, but so we have, again, the Mullen scores down here, receptive language, expressive, fine, and gross motor are the colors. And then their age in years with their age equivalent in months on the side. And it just kind of, for this group, there was sort of more of a cluster where the first, like, up to maybe age 5 or 6, we have scores kind of around 12 months, grossly on average, but then scores more around maybe kind of approaching 2 years old once kids are kind of over age, 6. So it's kind of those 2 kind of interesting chunks. So again, I feel like these kids are able to show me plenty. We want to track their development. And in fact, maybe they just need a little bit more time to be able to show us some more skills. And so why not kind of give that to them and then, track them over time. So that's what I kind of have for the duplication deletion kiddos. And then I think we're almost done with some of the data. I know this is a lot of graphs, but I'm excited to show the data just because it's a lot of work for families to come in. If you have come in, you're with me for like 4 hours, there's all these questionnaires, there are kiddos working hard. And it's really, 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 I feel really fortunate to be able to present the data to you. Okay, so anyway, this is the measure that I was talking to Dr. Grinspan about, called the BASC. This one looks at social emotional development. And so we have all the ages. I put them in order from like youngest to oldest, but now that I'm looking at the color scheme, I really should change that next time I present this, so it's a little bit easier to digest. But you can see the indexes, their names, so hyperactivity, aggression, conduct problems, anxiety, depression. Somatization is kind of like just like body, like could be headaches, stomach aches, things like that. Atypicality is this index, which we'll talk about, withdrawal and attention problems. And so again, this one after kind of 65, since we're talking about T-scores, is where we start to say these are kind of more problematic than parents of other kids this age report. And so for us, it's really the hyperactivity, not all of the kids though, quite a lot of the lines are below the line. But the ones that are above are kind of hyperactivity, maybe a little bit aggression, kind of just 1 for conduct problems. And then this atypicality index has quite a few, and then some kind of in the attention domain. So I think this is kind of in line with what gets reported often. The hyperactivity is very easy to see, so very easy to report. Attention problems as well. The atypicality index on this questionnaire is kind of not it's not my favorite, but I do find that it gives me data that I will interpret when I give the SRS, which is data I'll present in a little bit. And so
What does atypicality index mean? What is like atypical behaviors for their age, or like what does it mean exactly?
yeah, it just kind of means odd behaviors, for lack of a better, that's how they describe it in the manual. So it might be kind of like, I mean, to be honest, this index will be elevated for me when I have kids with seizures, because sometimes it just says looks off, stares off into space, and is hard to interrupt, and things thinks things that has difficulty distinguishing fantasy from reality, questions like that. So it's interesting to kind of think about why this index is elevated. I mean, we do that for any etiology coming in, but the social data then is important, although for some reason I'm not seeing it on my next slides, which I'm confused about. So I can maybe we'll go back to that later. That might have gotten deleted by accident. Okay, so that's kind of the data, how the data is starting to come together, and where it's the three groups that we have, the inverted dupe del and the deletions only and the duplications only, are starting to look different. But I did want to kind of take another pause here to sort of just reiterate why is studying development in AP important. And so, the first thing that I sort of already mentioned earlier is that it can be used to assist with future planning, and having this data now could be really useful for a family who gets a diagnosis and a young child of some form of AP, so that we could have some idea kind of what to tell them to expect. Obviously, we don't have a 100%, crystal ball, but some guidance I would think might be helpful. Just to put in kind of another plug for doing neuropsych testing, just because I do think, I mean, it's a big day, it adds a lot of time, but I think the schools take our reports pretty seriously, so it can be used to guide IEP goals. It's a great way to just make sure that the school understands what kind of age equivalence your child is at, so that we are simultaneously teaching them at their level and kind of then expanding from there. Oftentimes when I hear about, behavioral difficulties in school, a lot of times, not every time, but a lot of times it's because the goals or expectations are too high for your child, and your child reacts, but then they get blamed, and I just really like to avoid that, because I don't think that that's truly what's going on. I don't think they're just trying to be difficult. I think they're trying to tell the teacher or the staff that what's being asked of them is too hard. So I think it's helpful to have somebody outside of the school kind of, report some of these numbers and these age equivalents. That again, then the school can kind of hopefully, change their tactics if necessary. I think it can also be used, most of the kids that we see, and I'm sure a lot of you on this call are in speech therapy, occupational therapy, physical therapy. So some of my data can also be used to shape that. Sometimes I think my data can also be used to help families know if they could pull back, on one therapy and increase another therapy, or, to see if all of this work that you're pouring into one therapy, how has it translated into kind of day-to-day stuff, so just because we understand that there are not enough hours in the day and not everything can be a lesson, I think sometimes it can be helpful for families to know how to stack their kind of what to emphasize, for the next 3 months, 6 months, or a year. And so those are sort of the immediate benefits kind of to having a neuropsychological evaluation completed. And I guess I'll just take a second to also say, we don't have an age limit in our clinic. So we see kids all the way up to at any age they want to come in, and we will do testing and we will get numbers. And so even if your AP hero is in an adult day program or doing kind of a supportive employment, I think it's still useful to, kind of check in and see how they're doing, especially if they're in an adult day setting where sometimes it's hard to know like what their day consists of and is it enriched enough. And or if your hero is in the later grade or starting to be in middle school, some families have questions like, should we keep learning academic skills or should we switch into life skills? And I think getting the data from MyEval can kind of be helpful to guide some of those decisions. So just don't think that it's only for young kids. Okay, so like I was saying, those are kind of some of the immediate benefits. The other benefits, though, I think we're still trying to understand the drivers of these developmental challenges. So what changes, changes in AP we know cause developmental challenges, but kind of what parts of the genetic material are ending up to be critical for development, because this could form kind of basis of therapeutics in the future. So there's sort of a more longer term goal also of kind of what this developmental data can show us. Okay, so we kind of talked about how there is, there does appear to be some degree of cognitive impairment for most individuals with AP. Every individual that we have seen has had cognitive impairment, but of course there could be folks out there who don't demonstrate much. So that's why more information is always needed. So if anybody would like to come to our clinic, we would love to see you. For the kids with deletions only, there's a lot of words on the slide, but we are seeing a milder phenotype. Intellectual abilities are kind of around a standard score between like 60 and 80 is sort of what the data looks like, which is consistent with a diagnosis of mild to moderate intellectual developmental disorder. If you're assessing kind of kids with, or, your younger kids are going to be able to show us what they know best on measures of the puzzles, the working memory, and then picture naming and pointing to pictures. These are the ones that kind of tell us, I think, best about how to track their development. Once kids are in kindergarten, they're learning pre-academic skills, colors, sizes, working on letters and numbers. These should definitely be skills that are taught to these kids with deletions. At later ages, like we said, they are able to show us like solid early academic skills, early reading, early spelling, early math. So we don't want to kind of give up in those domains. But these kids also show behaviors that are consistent with autism, which is something that definitely adds an additional layer, I think, to need for therapies and a school who understands them and things like that. So evaluating for autism is also going to be important in kiddos with deletions. Like I said, for the kids with duplications, we have the small sample size, so 3 kids, and they're all fairly young. They do all meet criteria for developmental delay. And 1 kiddo, had gaps kind of before age 12 months. That just kind of means developmental delay, but what our group needs to do, and hopefully we'll see some more kiddos with duplications, is to see what this looks like over time. Do any of the gaps start to widen? Do the gaps get smaller? Do some kids not even have any gaps? This is still a question for me. And so the kids with inverted deletion duplication seem to have the biggest gap compared to their peers. Motor skills, though, are stronger than language skills. Most of them are walking. Social skills are also strong in this group. Skills kind of appear to be around a 12-year-old level that I mentioned, and then they sort of approach maybe more of a 24-month-old level once kids are a little bit older. And so the autism and the social emotional stuff is important. And so we are seeing that some kids will meet criteria for autism. Autism is different from intellectual disability, just in case there's any confusion there. Kids can have both diagnoses. Intellectual disability just means there's a gap in adaptive or cognitive skills compared to same age peers. But kids with autism have specific difficulties in social communication, which is kind of a broad category, and evidence of repetitive interests and restricted interests and repetitive behaviors. So, so they're not the same thing. Some of the behaviors can overlap, but this is an area that we want to make sure we don't kind of put to the side and just say, oh yeah, it's their delays, like, especially because autism can really affect families day to day and kind of in really challenging ways. And so families need more support. And so getting kids into therapies or centers for autism or ABA therapy, you know, are all things that we want to try to assist. So let's see. So in the autism domain, and I am really sorry, I do not know where that slide went. If there's time later, I can just show the Excel sheet with the graph on it. But the main distinguishing factor that I wanted to point out using this thing called the SRS is that the SRS breaks down challenges in social communication into a couple of different domains. And the social motivation domain is much less affected than some of the other domains, which I think is really interesting in this group. So, you know, these kids, that's not an area that we need to try to work on. Like, that's an area that we can capitalize on to kind of then layer ABA and other skills on top of. And so to me, that means these kids are sort of one step closer from benefiting from ABA or other kind of behavioral therapy, because they already want to interact kind of all already on their own. And so I think that's another really nice strength. Okay, let's see. Already kind of talked about this, behavioral difficulties, hyperactivity, attention problems. Some kids will meet in addition to intellectual disability and autism for an ADHD diagnosis. In order to make an ADHD diagnosis in a child with an intellectual disability, there has to be more difficulties than expected given their level of development. And so that's just kind of a discussion with the family. But sometimes kids will also meet criteria for that diagnosis. And then I just wanted to kind of reiterate that age isn't necessarily a factor, whereas sometimes younger kids have more challenges, older kids might have fewer challenges. So we want to just constantly evaluate for this domain as well. Okay, so then I just wrote some things that, you know, I still come back to that sentence in that one paper of like, kids are not testable, and like, why would someone write that? And so for me, my experience is just that like kids might require out of age testing, which is why today sometimes I presented age equivalents to you instead of standard scores. But basically, if you meet them where they are developmentally, like they're going to show you stuff. So it's really the job of myself or another neuropsychologist or the school psychologist to kind of figure out where that is. So if you ever go into, you know, an assessment and the provider, you know, works with your child for 20 minutes, like they didn't do their job and you should find someone else. You know, kids can show us plenty, as I keep saying. So sometimes when we do out of age testing, it limits some of the numbers that we have kind of afterwards. We might not have all the same amount of norm scores to look at, but some of the tests that I'm starting to use or just investigate more into have these things called GSV scores. Oh, sorry. Which are created from raw scores, which we have for all kiddos, and that will tell us when the change in raw score is statistically significant. So we can know if kids have made a statistically significant gain or a statistically significant loss. And so this, I think, is something that our group is going to be using more over time to try to argue that it's a good metric. So sometimes the age equivalents that I get from the out of age testing are sort of limited. Some tests will just say like the score is less than 3 years old, which I don't know what that means. And so it's hard for me to use that data. So that is a limitation. Today I didn't include that data. And then of course, as I was kind of saying with Dr. Grinspan too earlier, like families are already with me for 4 hours. And so I can't just do like every test that I would ever give, to your child. So it's hard to sometimes compare across tests, but the more data we have should kind of take care of that. And then the last point on the slide is just to say that, parent report is really essential. So I am forever grateful for all the questionnaires that families have filled out for me, because it really helps me interpret my data, which I also think is important. I think it's really important to see what the child will put forth and then kind of look at it combined kind of with the parent report. It is a snapshot. So, I always hear people say, oh, well, maybe the kiddo had a bad day and they just kind of, couldn't participate. And that happens, but to be totally honest, like it happened, I don't feel like it happens very frequently in my clinic. Kids will usually show me what they know. And sure, if they have a seizure or, something else, but I've had families who've flown in and then their kid works with me for 4 hours. So, it's just really a special group. So I kind of worry about that like less. And of course, we would always figure something out if you feel like your kiddo was not having a good day. Okay. So, time is just kind of going by here, isn't it? So I already I just wanted to end with this like sort of future directions, where more evaluations is kind of top of mind for me. The GSV scores is top of mind. Sometimes, like I was mentioning, seizures, how does therapies maybe affect developmental trajectories? And some of the most recent work that I've been doing talks about the size of the genetic change. So we talked about inverted duplications, deletions, and duplications today. But what if we kind of added up just all of the changes? And so this is some newer data that we just ran. And so basically this has the Vineland total score, but then I also wanted to break out the other scores, daily living, social, and communication, related to the size of the genetic change. Deletions, duplications are the total change. And we can see kind of similar to the data I think that I have that the deletion size doesn't really change any of these scores, but the duplication size does, and then kind of the total size is significantly related. So the bigger the genetic change, the more impacted or kind of the lower are the Vineland scores, is what this says. Now, so that's just sort of a place to start. It's just correlational. I have this plot that shows the genetic change on the bottom with the ABCs just mapped to the 1, the ABC score here, kind of going down. And so to me, this is enough that says, though, is that what's happening with the deletions only? Like, yes, their cognitive profiles seem to be less impacted, but what about the actual like genes that are there? And is it the fact that most of the kids who've seen us have a similar deletion? Is it kind of masking something that's going on? So I think the next step is to really look further to see in that change, what genes are involved and are they specifically kind of driving any of the developmental changes that we're seeing. So that's kind of the next adventure. And then, so that's what I've got. So that's what I've got for today. Just wanted to thank everybody, all the families who've come, or if I've met you at the conference, just a fantastic group, our coordinators, and then our research folks. And then this is the director of our clinic, Scott Demarest. Okay, whew, now I'm onto this slide. Happy to, I think I was seeing some of the chat come in, so sorry if I was just like talking too fast, but what do we have there? What can I answer? So I'll leave this up.
Well, thank you so much, all. And if there are any that want to come off mute to ask a question as well, please feel free.